This is Module 2 of the educational program promoting successful rehabilitation outcomes in multiple sclerosis. This module will focus on spasticity and weakness in MS. The primary weakness that we observe in multiple sclerosis is due to the demyelination and axonal degeneration that was described in Module 1. As a result of the demyelination, we can develop difficulty with propagation of action potentials along the axons. That can result in physiologic fatigue, paresis, and even paralysis. This primary MS weakness, meaning weakness specifically resulting from damage to the axon and demyelination, is most commonly evident in anti-gravity muscles in the lower extremities. We'll see weakness in the iliopsoas, the rectus femoris, the hamstrings, and the anterior tibialis. We also have secondary weakness in multiple sclerosis, and this is most often due to disuse, deconditioning, and development of compensatory movement. This occurs when the individual is challenged with primary weakness and as a result starts compensating their motion by using other muscle groups. Certainly from poor positioning, we can see muscles that are elongated and become weak. We see the development of contractures with soft tissue changes in the muscles. Unfortunately, sometimes the occurrence of pain, proprioceptive loss, and tendinitis. All of these contribute to the patient not utilizing their muscles appropriately. Contributing factors to secondary weakness include spasticity, ataxia, and an imbalance of the agonist and antagonistic muscle. Muscle imbalance that is observed from a secondary or prolonged sitting posture is most often demonstrated in the muscles of the hip and pelvic region as well as the trunk. So individuals who are in a seated position for a prolonged period of time will have shortening of their hip flexors. The sitting position itself will contribute to poor posture, rounded shoulders, tightening of the pectoralis major, potentially a development of kyphosis, all which contributes to balance problems in standing. Lack of activation of the trunk flexors, the rectus abdominis, obliques, transverse abdominis, as well as trunk extensors, the erector spinalis and paraspinalis, also contribute to difficulty in standing and maintaining an upright, balanced posture. Overstretching of muscles, such as the gluteus maximus, will contribute to weakness. We have the weakness of the musculature, and we should also take note that as the muscles become weak, so too do we see changes within the musculoskeletal alignment. The picture at the bottom of this slide depicts on our far left a normal upright posture, and then unfortunately with gravity pushing us forward, our head starts to drift into more of a protracted position. We start to see the development of the kyphotic change within the thoracic spine, and the picture on the far right is showing an individual that not only has poor posture and significant changes in muscle strength, but is also most likely presenting with pain in the upper cervical spine. Tightness of the pectoralis major and minor, latissimus dorsi, and upper trapezius all contribute to further difficulty with the individual being able to utilize their upper extremities with this change in their kyphotic posture. To assess weakness in multiple sclerosis, we should use the manual muscle test. And in any patient with neurologic dysfunction, we should test the patient in gravity and gravity-eliminated positions. Let's take a look at a patient who has hip flexion weakness. Our patient here is seated, and the therapist is asking him, believe it or not, to do hip flexion. Now he's doing knee extension, and you see that the quadriceps are able to fire, even able to take a little bit of resistance to quadriceps knee extension and hamstring knee flexion. Dorsiflexion is also apparent there. However, please note that the patient is wearing a dictus band, and we'll talk about that a little bit later in one of the modules. The therapist is showing it's just a band that goes around the ankle with Velcro closure. There are 2 clips that go in the eyelets of the sneaker, and it simply assists in picking the foot up through dorsiflexion for swing phase. The patient is actually even able to take some resistance in anterior tibialis activation for dorsiflexion. Now, recall that the patient could not hip flex in the sitting position, so we're now testing in gravity eliminated. But look at the struggle the therapist is having to flex that knee. That's the presence of spasticity in the quadriceps muscle. That might be one of the factors why he can't hip flex, because look at the force he can generate now. In a side-lying posture, once the spasticity is neutralized, he is able to generate terrific force for the iliopsoas muscle. As we just observed in the video, extensor spasticity in the lower extremities can interfere with the patient's ability to activate their flexor muscles. Spasticity, we know, is characterized by abnormal muscle firing, impaired voluntary control of the skeletal muscles, hyperactive reflexes, the presence of clonus, which signifies a more significant state of spasticity, often pain from the muscles being in this constant state of spasm or contraction. And we know that spasticity affects 85 to 90% of patients with multiple sclerosis, and it can occur early on in the disease process at that lower EDSS level, and certainly all the way up into the advanced stage of disease. Factors that increase spasticity certainly include relapse of the disease, that problem of infection that we mentioned previously when the patient has a urinary tract infection, that can trigger the spasticity to become intensified. If a patient is fatigued, either MS fatigue or fatigue from the results of activity throughout the course of the day, that can cause an increase in spasticity. Excess of activity, presence of pain, stress, anxiety, even constipation can cause an increase in spasticity, and clothes that are constricting in nature. The physical therapist must perform differential diagnosis to determine if the exacerbation of disease or symptom magnification is due truly to a relapse of the disease, or is it in fact a secondary complication from symptom magnification. Potential consequences of the presence of spasticity include increased energy cost of movement, which really contributes to more fatigue that the patient experiences, certainly an impact on their gait and transferability, presence of poor posturing and positioning in the chair, safety issues as the patient may not be able to sit properly in the chair and start to slide forward, the development of contractures, pain, discomfort, sleep interruption, especially with spasms that occur in the lower extremities during hours of sleep, skin breakdown if the patient is not able to reposition themselves in the chair due to the presence of spasticity, interference with hygiene, self-catheterization, sexual difficulties, and even interfere with the patient's ability to breathe. We assess spasticity by utilizing the modified Ashworth scale, which is an ordinal scale that runs from 0 to 4. In the MAS, or Modified Ashworth Scale, a 0 would reflect no increase in tone, or a normal state of tone. A 1 represents a slight increase in muscle tone, manifested by a quick stretch, but then a release of the spasticity. A 1 plus means that there's a resistance with the quick stretch, and that resistance persists through the remainder of the range of motion. A 2 demonstrates more marked increase in muscle tone throughout most of the range of motion. Increased resistance with quick stretch confirms that limited range of motion is in fact due to spasticity. You can easily detect a 2 because as soon as you start to passively elongate the muscle, you feel resistance. A 3 is considerable increase in muscle tone, and now attempts at passive movement or elongation of the muscle is extremely difficult. It is still important here, if you're suspecting a MAS of 3, to perform that quick stretch so that you can confirm that in fact the problem is one of a spastic nature versus contracture. A 4 reflects that the affected parts are rigid in either a flexion or an extension posture because of the spasticity. We see functional limitations associated with spasticity and weakness, and those will be demonstrated on the next 3 videos. We see with our patient Mike the difficulty that he has in advancing the right leg forward through swing phase because of spasticity and even the loss of balance. In Jean, we see the difficulty that she has in transferring because of the spasticity in both lower extremities, and as well the weakness in her trunk in a posterior pelvic tilt. And as we see with Andy walking with a wide-base quad cane, no motion of the upper extremity or lower extremity due to weakness and spasticity. As we just saw in the previous video with Andy ambulating with the use of a cane, weakness and spasticity can cause specific gait deviations. We see circumduction, which was demonstrated in the video with Andy as he had to hip hike and swing his leg out to the side to clear it through swing phase. Often our patients will also vault on the stronger leg, that is, lift the body up, in an attempt to clear the weaker leg through swing phase. The presence of genu recurvatum is a telltale sign of the presence of spasticity in the gastroc soleus. As the patient moves through stance phase on the involved extremity, that spastic gastroc pulls the proximal tibia posterior, resulting in hyperextension of the knee. We should always first look at gastroc soleus for spasticity as well as weakness when we see genu recurvatum demonstrated. After that, then go to the quadriceps. Foot drag is certainly evident with weakness of the anterior tibialis. A shuffling gait, or both feet sliding on the floor, is indicative of spasticity as well as weakness of the anterior tibialis. Spending less time in stance phase on one extremity is an indication of weakness, and they're quicker to swing that leg through. Lateral trunk flexion can assist with contralateral swing, and we also see a decrease in push-off as the gastroc muscle is the primary muscle for acceleration of the body forward during the gait cycle, which caused the difficulty with his gait. We will now view the video of Andy going through an examination which will demonstrate the weakness and spasticity which caused the difficulty with his gait. We'll start our examination of strength with the patient in a seated position, going through hip flexion, knee extension, knee flexion, dorsiflexion as well as plantar flexion, and we see no resistance to active motion there. In fact, the patient is able to take resistance through all of those motions. But recall when we saw Andy walking, he had more difficulty on the left side of his body. So really the revealing factor will be active range of motion and manual muscle test here. We're asking for hip flexion, much difficulty. Look at the overflow in inversion and knee extension when he attempts to hip flex. He can knee extend, activating the quads. He has a little more difficulty moving into knee flexion because the quads are still firing, potentially from spasticity. Difficulty now with dorsiflexion, possibly because of spasticity in the gastroc and soleus. So we're definitely seeing weakness in a seated position in the left lower extremity. This would cue us, we have to put him in that gravity-eliminated position so we can look at his strength when we've neutralized spasticity. And similar to our demonstration with Mike, we see Andy now has much better iliopsoas activation, inside lying, gravity eliminated, as well as with spasticity neutralized. The therapist is having some difficulty flexing that knee because of the firing of the quadriceps. But here is gluteus medius with a shorter lever arm, the knee flexed, and he is able to activate the abductor muscle. Therapist again being challenged a bit, neutralizing that knee. Now we're asking for dorsiflexion in gravity eliminated position, and that's a little bit more challenging. Look at the overflow of the quadriceps. When he attempts to dorsiflex, we're actually getting knee extension. Unfortunately, a very good demonstration of how spasticity gets in the way of isolated muscle control. Here's hip extension. Nice activation of the gluteus maximus. Spasticity neutralized with the knee flexed, turning off the quadriceps, and yet still some overflow in that quadriceps muscle as he attempts to extend the hip. Now trying to move back into hip flexion. The spasticity, as you can see, is very problematic for our patients, not only with multiple sclerosis, but with any neurologic condition. Here's attempts at abduction, gluteus medius activation with a long lever arm with the knee in extension, and then the potential for gastroc spasticity. Now we've put Andy in a supine position so that we can do the modified Ashworth scale and look for the presence of spasticity. Recall the right lower extremity was stronger, took resistance, and as the therapist is passively taking Andy through the range of motion, not really picking up any resistance to the quick stretch. Knee extension was fine, the quadriceps, the hamstrings. Now we're seeing gastroc. She's flexing the knee so we can isolate the soleus. Quick stretch, maybe a little bit of a catch, a 1 at best on the modified Ashworth scale. Now we're going to go over to that left extremity where we saw so much spasticity before. Little cheating technique for the quads, putting the patient in straight leg raise, and then elongating, and then quick stretch down, can test the hamstring coming up and then the quads going back down. And notice the resistance in both directions, quads and hamstring spastic. Here's the gastroc on that left side and a catch there. And it looks like not only the catch but resistance through the remaining range of motion, which would be a +1 on the soleus, a catch, probably a 1 on the soleus muscle. Here's abduction, so elongating the adductor muscles, which are often spastic. Clear the muscle once and then a quick stretch, and we definitely see a catch there with continued resistance through range, a +1 on the MAS. Now we're going to have Andy move into a side-lying posture so we can more accurately assess the presence of spasticity in that quadriceps muscle. The therapist has resistance simply flexing the knee, so we know that there's resistance to the range, elongation of the muscle. It is then confirmed with the quick stretch, and you saw there the increased resistance as the therapist gave a velocity change to the elongation. That confirms for us the problem is spasticity. Now we'll have Andy move up into a seated posture again, now to focus on that arm, because recall we did not see arm swing during his ambulation. You can see noted weakness in the left upper extremity, unable to go through full active range of motion, certainly in the shoulder girdle, some limitation with elbow flexion, biceps activation, and look at some of the difficulty he has there with his wrist and hand. Interossei weakness. Question is there also spasticity present? So now the therapist is going to elongate the biceps muscle, clearing it, and then the quick stretch, checking for biceps as well as triceps catching. And here's biceps coming down and quickly elongating the muscle to see if there is resistance to that movement, and there is a catch there. There was a catch both in triceps that we just saw and then biceps. Here's the wrist flexors with the fingers extended and a catch there as well, in addition to the weakness that we saw with active range of motion of the entire upper extremity. As with all of the patients that we see in rehabilitative care, we should always incorporate standardized measures. Standardized measures that could be appropriate across the range of the EDSS that we're examining in this video would include a static sit test, repeated sit to stand, timed 25-foot walk, which is the gold standard, if you will, for multiple sclerosis, and then the timed up and go test. We'll now see patients demonstrating each of these 4 standardized measures. The first standardized test is the static sit test. The therapist is cueing the patient to sit in a more upright posture, moving into more of an anterior pelvic tilt, asking her to hold that posture and then timing the patient. Typically, we would ask for a 2-minute holding posture in static sit, without the patient needing to put their hand down to hold themselves upright. The next test is the repeated sit to stand test. The patient is asked to stand up and sit down 5 times as quickly but safely as possible. As you can see, a chair with armrests is utilized, and the therapist is timing the patient how long it takes her to safely perform this task 5 times. Repeated sit to stand task. And as you can see, as the patient continues to do the movements, she has more and more challenge, possibly due to more muscle weakness, spasticity, as well as fatigue. The next test is the gold standard, the timed 25-foot walk test. The patient starts at a start line, and as soon as heel strike is initiated after the start line, the stopwatch starts. The patient walks as quickly but safely for 25 feet down the hallway, and as soon as you have first heel strike after the stop line, the stopwatch is stopped. The timed 25-foot walk should be performed 2 times. So the patient turns around, they can do a standing rest, and then they initiate the test again. The best time that the patient is able to achieve for the 2 trials of the timed 25-foot walk is utilized as the demonstrated performance of this task. It's a nice demonstration, again, unfortunately, of Andy's difficulty in advancing that left leg through swing phase. The other standardized test is the timed up and go. The patient starts seated in a chair, is then cued to go. They can get out of the chair using the armrests, walk 10 feet, again to that stop line, turn, and again walk as quickly but safely back to the chair. The stopwatch starts with the therapist's command of go and stops when the patient is safely seated back in the chair. Timed up and go test. When establishing goals for physical therapy to address the presence of weakness and spasticity, we are most often focused on ambulation. And when we're establishing goals for ambulation, we should be thinking about speed, predominantly to cross a street or parking lot successfully, as well as endurance and safety. Certainly we want to be concerned with safety for all mobility, even including bed mobility, sit-to-stand, and toilet transfers, and that takes us into facilitating activities of daily living for the patient. The more we can increase their functional mobility and their safety and independence in transfers, that will obviously decrease the burden of care for their care partners. As we address weakness and spasticity in our goals, we can also reduce pain and prevent the development of contractures. When we manage weakness in multiple sclerosis, we need to be focused on the primary weakness, which again is a direct result of the disease process, but we also need to focus on secondary weakness, which is often overlooked, and often as a result of disuse or deconditioning. In primary weakness, we want to work on strengthening those muscles in task-specific activities, which will promote the patient's ability for motor relearning. At times, as the disease progresses, we may be required to develop compensatory interventions and the use of mobility aids and braces such as AFOs and KAFOs. In secondary weakness, again, which I mentioned is often overlooked, we need to minimize this with early intervention and appropriate follow-up to work on posture and core stability, correct that compensatory gait whenever possible, encourage healthy lifestyle, and teach energy management strategies to counteract the effects of fatigue. In MS can be demonstrated in the following video. Our first examination of Mike's gait is with the use of the straight cane and the dictus band, which he's wearing on the right lower extremity to assist with dorsiflexion and swing phase. There is certainly mild gait deviations as he's walking, slight lateral trunk flexion to the left, hip hiking on the right. But Mike is quite safe and independent in his ambulation with these two devices, and it certainly conserves energy. To have a greater appreciation of his gait deviations, the therapist will now remove the dictus band and take the straight cane away. She simply disengaged the band. Now we'll see the true gait deviations that Mike has and the potential for compensatory patterns, as well as catching that toe through swing phase, which then puts him at loss of balance and potential for a fall. If that wall had not been there, the unfortunate incident could have occurred where he truly lost his balance and suffered a fall. Look now at the difficulty in advancing that right leg forward. A lot more energy consumed as he tries to compensate for that spasticity and weakness in the right lower extremity, and certainly is unsafe. As demonstrated in the previous videos, we've seen the impact of weakness and spasticity on functional limitations. So our focus will now turn towards treatment of weakness and spasticity. The emphasis should be on stretching those spastic muscles through slow passive range of motion using prolonged stretch, strengthening the muscles that are weak, and again, emphasis now on the trunk and the core, as well as strengthening the antagonist of the spastic muscle as a means to address spasticity. And a key area for any neurologic patient is task-specific training, emphasis on stair climbing, repeated sit-to-stand, gait training, and even using a body weight support trainer. We'll move into some demonstration now of treatment of patients. We'll start our demonstration with Mike, moving into a quadruped position as a means to start to address that hip flexion weakness which we saw in his gait cycle. So in quadruped, we're going to ask him to do hip flexion. Now there's some difficulty there initiating the iliopsoas muscle, but the therapist will remove the sneaker because it honestly could be the drag of the sneaker on the table that's limiting his ability to move into hip flexion. So we'll ask the patient to repeat the task again, and much clearer demonstration of the ability of that muscle to fire. So quadruped could be used as a means to activate that hip flexor, or even having the patient walk forward on their hands and knees. Now we're asking for hip extension, and you see the difficulty in activating that gluteus maximus muscle, not able to get that foot off of the table. Many patients with spasticity and weakness in the hip and pelvic girdle have low back problems. SI dysfunction is quite common, so incorporating orthopedic exercise and posture training exercise is also important with our neurologic patients. Here we're just doing repeated sag and cat exercises. As Mike moves up into tall kneeling, we're now asking for more trunk strengthening, and he can repeatedly go from quadruped to tall kneel as a means to strengthen his gluteus maximus as well as his back extensors. And you see the weakness there as he's unable to get into a full upright posture. The therapist is giving him some assistance on his left shoulder as he comes up. We'll go back to our friend Dio, who is a higher functioning patient, and we're going to have her demonstrate some of the other core exercises that would be appropriate for patients. Obviously, we're going to select activities based on the patient's ability, modify them to make them easier for the patient when they're more challenged, and obviously make the exercises even harder based on their ability. Dio is able to maintain a nice, tall, kneeling posture, and then we're challenging her by lifting that large therapy ball up overhead, and then also going through diagonal patterns, which is a nice way to incorporate the abdominal muscle, the oblique muscles, activating that hip and pelvis. She's getting nice weight shifting on both lower extremities. Recall she had the orthopedic problems in her hips and knees, so that's a way to eliminate that during her exercise. Now we're asking for hip extension, quite a difference from what we saw with Mike just a few minutes ago, supporting Dio on the therapy ball, able to go through full hip extension. Here's Andy, and recall Andy had quite a bit of difficulty with swing phase, activating the flexor muscles for swing phase as well as clearing that toe. So repeated step-ups on a low-level bar could be one means to activate the muscles. But again, we don't want compensatory movement. We don't want a lot of hip hiking circumduction. So the therapist will assist Andy in utilizing the muscles appropriately by facilitating that foot into dorsiflexion, a little facilitation on the hamstring muscle and gastroc in order to get the ankle, hip, and knee to flex. And repeatedly going through this movement would obviously help in strengthening those muscles and incorporate more normal movement patterns. We're going to have Andy step up again, and now what we'll ask him to do is to step down. The first step he's going to take is with his right leg, which then requires an eccentric contraction of the involved lower extremity. Then we ask him to step back up. Now we're asking for gluteus maximus, hip extension, as well as hamstrings, eccentrically activating the quads as he lowers down, the therapist assisting to get knee flexion and dorsiflexion as he steps back and activates opposing muscle groups. And then Jean, our patient who had the EDSS of 8.0. Recall that we saw Jean in a prone on elbows posture doing weight shifting, which is a terrific joint approximation exercise for the shoulder girdle. Even more joint approximation as she reaches forward, alternating each upper extremity. The therapist will now assist Jean into moving into quadruped position. And recall she did need some assistance with the hip and pelvic girdle as well as with the shoulder girdle. We'll now ask Jean to do weight shifting in this position so she can do anterior-posterior weight shift, which will transfer her weight onto her shoulders, then back onto her hip and pelvis. Again, getting joint approximation. Joint approximation is a facilitatory technique, an older neurologic tradition, to incorporate extensor muscles' proximal stability. We will even ask Jean to attempt some unilateral weight shifting on the upper extremity. You can see the challenge she has there, Probably be easier for her if we positioned her over a therapeutic exercise ball in doing that exercise. We'll come back to Jeanette. We saw her in static sit previously and repeated sit to stand. Now Jeanette will perform some trunk exercises, core strengthening, in a seated position using resistive band, activating the oblique muscles as well as the abdominals and back extensors, upper extremities being involved to pull herself, her trunk, into rotation, addressing both sides of the body. Again, vary the task as the patient is able to perform the activity, whether it's just reaching with a ball, rolling a ball versus using resistive band. Now we'll ask Jeanette to do some pull downs. Nice activation not only of the abdominal muscles but also the shoulder depressors as she pulls down. And then we'll change that activity around and ask her to pull up, which will be a nice way to work shoulder flexors and also start to work those upper traps and the upper paraspinal musculature, all focused on increasing her core strength, core stability. We'll move into use of the therapeutic ball. We saw Deal do that a little bit earlier in tall kneeling. We'll have Jeanette do the same thing now in a seated position. So in sitting, lifting the ball up overhead, asking for tremendous activation of her core muscles to maintain stability as she's challenged with the weight of the large therapy ball, lifting it overhead. And we can even ask her to go through diagonal pattern with the therapy ball, challenging her abdominals, her oblique muscles, and again her back extensors. It is also the responsibility of the physical therapist to communicate with the physician managing the patient regarding pharmacologic management of spasticity. The exercises that we instruct the patient to do will be helpful in temporarily reducing the spasticity, but having oral medication on board plus the exercise program will be the best intervention for the patient. Most common oral medication used to manage spasticity includes baclofen as well as Xanaflex. At times when the spasticity is more focal or localized to one or two muscle groups, botulinum toxin may be the choice to manage that spasticity. Botulinum toxin